All right, perfect. Well, once again, my name is Charles Wolin. I'm the Assistant Director of Alumni Engagement here at UC Hastings. We're actually coming to you live from the top of the new Kachet Law Center here at 333 Golden Gate Avenue. If you have not been, you can see the tower just over here. And then right behind me, you can see that little pole. That's where 198 is going to be rebuilt. So a lot going on at UC Hastings at the moment. Just some amazing things all around. But want to introduce you to Sarah Hooper today, who will be lecturing on the fight for health equity, protecting the rights of seniors and people with disabilities. Sarah is the executive director of the UCSF UC Hastings Consortium on Law, Science, and Health Policy, and lecturer in law at UC Hastings College of the Law. She's also an alum and graduated in 2008. She's also a senior Atlantic Fellow for Health Equity in the Fitzmullen Health Workforce Institute at George Washington University. Professor Hooper teaches a number of courses in the health law program at UC Hastings and is the faculty advisor for the J.D. concentration in health law and policy. She also serves as the co-director of the Master of Science in Health Policy and Law degree, which is HPL, and the policy director of the Medical Legal Partnership for Seniors Clinic. Sarah has dedicated her entire career to developing innovative medical legal collaborations that can advance equity in healthcare. You're going to hear a lot about that today. She has special interest in complex care and in particular, the role of law and lawyers in improving systems of care for underserved older individuals with complex medical and social needs. Her work encompasses clinical interventions such as the Medical Legal Partnership for Seniors Clinic, research collaborations, such as the Care Ecosystem Trial, and educational initiatives for providers and the public, such as Optimizing Aging Collaborative and Prepare. Her scholarship has been published in peer-reviewed journals, such as the Journal of Health Politics, Policy, and Law, Journal of Pain and Symptom Management, as well as the Health Affairs blog. So Sarah joins us now. Welcome, Sarah, and feel free, everybody, to please continue to be on mute. If you have any questions, DM myself or Sarah, but over to you, Sarah, and good afternoon.
Hi, thanks so much for having me. It's really a delight to be here with fellow Hastings alum and with members of our community. I'm really excited to share with you some of the work that we've been doing in the consortium and to invite your ideas for work that we could still do. So I thought that we could start with a story from our own community. I want to talk about Mr. S. Mr. S was a 72-year-old man who lived alone in Oakland. He was a veteran and he lived on about $24,000 a year. His neighbor checked in on him periodically and was concerned about how he was managing on his own. And one day, Mr. S called to ask his neighbor if cat food was safe to eat. And the neighbor decided something needed to be done. So he packed Mr. S into the car and drove him over the bridge to a hospital in San Francisco, where he thought the hospital staff could do something. The hospital staff evaluated Mr. S and determined that he had undiagnosed dementia, COPD, and diabetes that had been poorly managed. And they determined that while he did need help, it wasn't of the kind usually provided by hospitals, and he didn't really need to be there. However, the team didn't think it was safe to discharge Mr. S back to his home. So they looked into long-term care options and encountered just a slew of barriers getting him access to those supports. And Mr. S didn't have any legal caregivers to navigate these things for him. And so the team decided that conservatorship was the answer, and a conservator would be able to identify resources for him. So the process of figuring out Mr. S's discharge plan took months, and the conservatorship process was going to take even more. And throughout this process, Mr. S was growing increasingly depressed living in the hospital, and he said it felt like prison. But he couldn't articulate a plan for how to live safely at home, and so the team didn't feel comfortable letting him return home. Mr. S ultimately lived for 6 months in the hospital and died of a complication before he could go home. This shouldn't happen, but unfortunately it does, and is a problem hospitals are grappling with in our community and in hospitals all over the country. And it happens because of a series of policy and spending choices that we have been making in the United States over the past 40 years. So here I'm drawing on the work of Bradley, Taylor, Don Berwick, and many others. So these aren't my ideas, and these are relatively well-established ideas in the field, but we can think about 4 big picture trends over the last 40 years. So first, the healthcare system is increasingly fragmented in the way we deliver care and pay for that care. So Mr. S, as a low-income older veteran, has 3 potential payers for his medical care, none of which fully cover what he needs, each with slightly different rules, and they each don't coordinate with one another. His primary care doc, if he had one, was not the same doctor he saw in the hospital, and indeed he wouldn't have even seen the same hospital staff over the course of one day. And none of these providers communicate well with each other. It was up to Mr. S to do that, right? Second, our social care systems are also fragmented, underfunded, and disconnected from healthcare systems. So Mr. S needed food, stable housing, an in-home caregiver, and someone to help manage his bills for him. And at some point in the progression of his dementia, it was likely that he would gradually need more supportive housing in the form of assisted living or other long-term care supports. But each of those social safety net programs also has its own slightly different rules, and it was also up to Mr. S to navigate those. So third, we've seen a profound and growing economic inequality and erosion of structures that used to create stability in retirement, like pensions and defined benefit plans. So the effect of that is that individual consumers are now asked to navigate their own financial resources, systems, and the stock market in order to provide structures in place to support them during illness, disability, or old age. And finally, but critically, we have seen the persistence of deep social inequality and structural racism, which evidence shows that even after controlling for other factors like socioeconomic status and individual health behaviors, these social inequalities and structural racism account for poor health outcomes, premature aging, and more rapid onset and progression of disability. So as just one example, as an older American of color, Mr. S was at higher risk of dementia, was unlikely to have that dementia diagnosed, and of course was more likely to experience discrimination in his care. And structural racism also helps explain why his neighborhood didn't have sufficient medical and social supports that he knew how to access, why his retirement income was smaller relative to white peers, and why his social network no longer lived near him and had their own stressors inhibiting their ability to provide care and support. So lifetime factors such as housing segregation and employment discrimination set the conditions into which Mr. S lived, aged, and died. And the confluence of these trends help explain, how we got to Mr. S's story. And collectively, these systems place a cognitive, mental, physical, and financial tax on people in navigating these systems. And we expect them to navigate these systems often at the time that they are least able to do so. It also helps explain why, despite the fact that we pay more than any other country for healthcare, our older Americans are sicker, more medicated, and facing higher costs than their global counterparts. And we routinely underperform relative to other developed nations in other health categories as well. And so however you feel about the organization and funding of these systems and how we should approach that, a fact that has become more understood by experts and that people should really understand is that these inequities come at a cost to all of us too. So people like Mr. S represent about 5% of healthcare consumers, but that group accounts for nearly half of all healthcare spending in the US. I'll say that again, 5% of healthcare consumers account for nearly half of all healthcare spending in the United States. So if you think about Mr. S, for a 6-month hospital stay at about $2,500 per day, the hospital spent $500,000 on a stay that Mr. S didn't want, that didn't meet his needs, and may have contributed to his death, and that the hospital said that they didn't think he needed medically. And so $500,000 is 18 times Mr. S's annual salary, right? That's a lot of money. And this is a theme among these 5%ers. They have medical and social care needs, but the primary safety net support system that they are able to access is hospital care, which is the most expensive system we could use and also the least equipped to actually provide what people need and want. So I hope by now I'm starting to convince you that in order to improve health and address health disparities, healthcare is not enough. We have to address social determinants of health as well. And so there's a growing movement in health policy and health systems to figure out how to do that. And a first task is to be able to really understand and define this population. And so the field that has emerged is called the complex care field. And currently there is no consensus definition of who falls within the complex care population. As you can see, there are some younger people that fall into this population. But most researchers agree that this population is disproportionately older, women, people living at or below 200% of the federal poverty line, people with cognitive, physical, and mental disabilities, and people who have additional so-called social risk factors. So these are things like social isolation, substance use, housing instability, and criminal justice involvement. So the good news, this is a lot of bad news, but I have good news, is that health systems are working to figure out how to do better here. And so in trying to understand this population better, they're trying to figure out how to identify Mr. S's before they come to the hospital and target supports and services to help them meet their goals and help improve their care. So screening and identification is a big step, intervention targeting, and development of interventions like intensive case management and coordination, interdisciplinary teams, community health workers and navigators, and referrals and linkage to community resources like food and housing. But a real gap here is that a majority of these models do not integrate law as a tool for addressing the needs of people like Mr. S. This is a wheel that is commonly used by groups like the World Health Organization and the CDC, and is well accepted as a diagram that shows the many factors that account for health of a population. So we have decades of research showing that the conditions in which we are all born, live, grow, and age affect our health and longevity in a much more significant way, actually, than health care itself. And of course, law shapes all of this, right? Law is structurally a really important determinant of health, both in positive and negative directions. So I gave the example earlier of how housing discrimination may have affected Mr. S's access to resources in his own neighborhood, but we know that good neighborhood and housing conditions promote health at the population level, right? So we can think about law and its shaping of these conditions as being both a positive and a negative force in terms of population health. But what's really interesting is that we also have emerging evidence that legal interventions could promote health at the individual level. So in 2017, Jack Tsai and colleagues published a study in Health Affairs showing that when unhoused veterans with cognitive and mental health conditions received legal advocacy as part of their care, their health got better. And what was really interesting about this study was that veterans saw improvements to their health even before their legal issues were resolved, right? So housing, income, food access, whatever it might have been. And so this suggests the possibility that there is something about just having an advocate that could improve your health. And what's also interesting is that they found a possible dose response associated with legal intervention. Okay, so what does that mean? It means that a small dose of legal intervention was found to be helpful, but larger doses were found to be even more helpful. So veterans who spent more time with legal advocates saw greater improvements in health, housing, and income than those who spent less time. And this was not a cost effectiveness study, but the authors noted that the average cost for each unresolved legal issue for legal intervention was about between $270 and $400. And they pointed out that the average direct cost of care for these particular patients was between $10,000 and $60,000. So the legal intervention created benefits that were often profound, but was relatively low cost relative to what we normally spend on healthcare. So it's important to note that this was a small study. It was not a randomized controlled trial, but it's really promising research, and we're hoping to see more research like this. So law and legal intervention is a really important part of this movement to address the needs of people like Mr. S. But how do we do that? Well, this is the work the consortium has been doing for about a decade now. Our approach has been to work within multi-stakeholder and multidisciplinary teams to test and study interventions that leverage law and then help to disseminate them nationally. And a big part of this work is learning how to talk to one another across disciplines, across segments, across life experiences, to develop a shared language and to help reduce some of the complexity that people are facing. So this here is from a publication of ours in Health Affairs that mapped civil legal interventions to health indicators so that health systems could understand how legal issues show up in hospitals and clinics as health issues. And we suggest some things in this article that health systems can do using population health tools to identify and support patients like Mr. S before his care becomes a crisis. So one of our models is the medical legal partnership for seniors. And in this model, faculty, staff, and students here at Hastings provide direct legal advocacy to low-income older adults in San Francisco, in hospitals, clinics, long-term care facilities, and in their homes. And one of the most important things MLPS does is house calls along with healthcare providers. So imagine for a minute if Mr. S had a medical legal team to meet him in his home before he was hospitalized, right? That would make a significant difference in his case. And an important difference between the medical legal partnership model and other legal aid that's currently in the community is that our referrals come from healthcare providers. And they come from healthcare providers because people like Mr. S really struggle to self-identify legal needs and experience barriers accessing traditional legal care. But a healthcare provider who is trained by us to understand and recognize these needs can talk to him about it and say, let's talk to my friends who can provide you free legal help. And so this is really critical to reducing barriers to legal care that people normally experience. In 2019, we began working with UCSF faculty at the San Francisco VA on a new initiative called the Transitions Referral and Coordination Team. And the purpose of the team was to meet weekly to discuss complex cases. And our role has been to provide legal needs issue spotting and accept referrals for direct patient advocacy in a range of issues including appointment of surrogate decision makers, to long-term care advocacy, to housing and other matters. And we have helped VA providers understand and unpack the issues facing patients like Mr. S, and to help identify appropriate solutions. And so one of the major lessons we learned is that the healthcare team really overestimated the help that Mr. S would get in a conservatorship. Mr. S, people like Mr. S don't often actually need conservatorship. He needed help navigating and advocating for access to home and community-based long-term care supports. Conservatorship was not going to change the resources available in the community. The Public Guardian's Office does not have the power to change the Medicaid payment rules or to create new living facilities if there are no available beds. All it was going to do was strip away his civil rights and drain resources and time that he didn't have to spare. And we have also learned a lot for ourselves about the barriers healthcare teams face in navigating these resources and how physicians and geriatricians think about and evaluate capacity. So this has been a really, I think, rich learning experience for everybody, and has really enriched and made better the work that we all do with and for people like Mr. S. And what we found in this multidisciplinary and rights-focused approach is that it is actually consistent with cost containment goals. So when the track team meets to put heads together about complex cases, we can identify resources in the community and reduce the time people like Mr. S need to stay in the hospital. And so we've recently published this data that you see here in the New England Journal of Medicine, and we've been talking to hospital teams all over the country to urge them to take the same approach. Another model we've been working on is called the care ecosystem. So imagine for a minute if Mr. S or his neighbor had someone they could call, kind of like a 911, but for help navigating the healthcare system and resources in the community. That's what the care ecosystem is designed to do. So this is a patient navigator intervention that is designed to improve care to individuals with dementia and their caregivers. The patient navigator is an unlicensed but specially trained member of a healthcare team who assists patients and caregivers in navigating all of these things. And so the model has many aspects of it that are really important, and it's not just a legal intervention. There's medication management, there's communication with primary care, there's social work, there's a whole bunch of things. But as one part of this model, we designed something called the decisions module, which is a set of screening tools and workflow protocols, referral networks, and trainings, which equip the patient navigator and the healthcare team to identify and respond to legal needs of this population. So these are things like identifying a need for advanced care planning, planning for financial and legal caregiving, understanding health insurance programs, in particular long-term care coverage, which people really struggle to understand, and a whole host of things. And so we originally designed and tested this in 3 states, California, Iowa, and Nebraska, and we are now working to scale it to additional health systems in Louisiana, Minnesota, and Wisconsin. So we tested this model in a randomized controlled trial of about 1,500 participants, and found that Care Eco improved quality of life for patients, reduced ER visits, and reduced caregiver depression and self-reported burden. So a really important model. We've also developed something called prepareforyourcare.org. So Prepare is an online decision support tool with the option to complete an advance directive that is created through a collaboration with UCSF and designers who specialize in health literacy and vulnerable populations. And the website assists people with advanced care planning using videos and worksheets that show you how to do things. So it models things like how to ask questions of your healthcare providers, how to talk to somebody about if they would be willing to help you make decisions if you can't make them entirely on your own. Um, and it was developed using analysis of the law of all 50 states, of course, using current clinical and scientific evidence of kind of effective behavioral practices in advanced care planning. And then we're doing a lot of testing and validation with healthcare providers, lawyers, and patients around the country. So this tool is available for free to the public in all 50 states and in multiple languages. And in randomized clinical trials led by my colleague, Rebecca Sidore, Prepare has been shown to increase advanced care planning in English and Spanish speaking older adults, and to increase medical record documentation by healthcare providers. And this is really important because research shows that Black and Hispanic Americans are less likely to be asked about their goals of care and are less likely to have made plans. So we're taking the lessons that we've learned from Prepare, which really focuses on healthcare medical decision-making. And we are going to start focusing on creating a similar tool focused on financial and legal decisions. So we just recently got a grant from the National Institutes of Health to extend our work on Prepare to that realm. And we're going to be starting by asking patients, caregivers, advocacy groups, and experts what they need and want from such a tool, and we'll be building it over the next several years. And finally, we really need a health and social service workforce that understands the civil legal rights and needs of people like Mr. S. And so since 2015, we've been working with the collaborative that includes folks that you see here. And the goal is to work across these entities across Northern California to provide education and innovative services that address older adults' health, social, and legal needs. And the GWeb program is actually a national program funded by the Health Resources and Services Administration. There are other GWEPs around the country. And unfortunately, we are the only GWEP that includes legal services as a partner. And so we are hoping to see adoption and integration of more legal partners in these models going forward. So there's a long road ahead. We need to refine health and social service integration models like the ones that we're developing. We need to learn more about how these work, what are the best places to intervene, and what dose of legal intervention is most helpful, and who is best able to develop legal services, right? So ideally, everybody would have a lawyer, but we just simply don't have that capacity to do that. So how effective can patient navigators be in delivering linkages and supports? And then, there needs to be more research on the health and system effects of legal intervention. So what are those effects and how long-term are they? Will healthcare payers pay for legal interventions? They're actually already experimenting with paying for things like housing and enhanced care coordination. So you may have heard that hospitals are directly paying for housing. Entities like Kaiser have started directly paying for housing and food and other supports and enhanced care coordination. So a question is, will legal services be included in those services? And then, as health systems use population health data and tools to identify complex care populations, will the methods they use to define and target those populations be ethical? Will they have beneficent intent, but run afoul of the needs and rights of people like Mr. S in the process? I think it's a real question and something that definitely keeps me up at night. So I'm going to stop there because I'd really like to have a conversation with you, and I would like to invite your ideas and comments and questions. And we may have one in the chat. So thank you.
If anyone has any questions, feel free to drop a question in the chat, or if you'd like to raise your hand and ask the question and come off mute, feel free to. I guess I'll start first, Sarah. How does the federal government get a little bit more involved, potentially with programs that's the full consortium of GWEPs across the country? Is there a roadmap to it? I know you had mentioned, yes, it's going to take quite some time, but what does that look like outside of California and other states? Can the federal government and the country, unite behind a myriad of GWEPs together?
Yeah, absolutely. So there's a lot the federal government could do. And important among those are efforts to reform some of the underlying structural issues that I described, right? And so a lot of the tools we've developed are tools designed to help people cope with the systems that we have. But really, a more fundamental intervention would be to shift those systems, right? And so I'm not optimistic that it's coming anytime soon, but there are certain proposals for incremental reform. So for instance, in the so-called soft infrastructure bill, there are, proposals to expand Medicaid coverage of home and community-based services. California has taken some steps to loosen eligibility requirements to make Medicaid long-term care a little bit less burdensome to navigate. Paid family and medical leave would certainly go a long way to helping caregivers. So there's lots of those sort of like structural things that the federal government could do that would address some of these problems. But of course, we're all seeing how that is playing out, and these folks don't have time, right? They don't have time to wait. And so what we could do to encourage models like these is help pay for them, right? So right now in California, we have something called the CalAIM demonstration. And so that is an effort to align payment and provider systems for entities that provide care to low-income older adults who rely on Medicare and Medicaid, right? So-called dual eligibles. And so there are efforts to try and make those systems more friendly. And there are also efforts to enable Medicaid managed care plans to directly pay for social interventions like food and housing. So basically, we usually think of healthcare coverage as covering hospitals and clinic visits, but what we're saying here is that health plan coverage would actually cover food, housing, things like that. And unfortunately, legal services did not make that list of what are called in lieu of services. But it is possible for individual plans to decide to include them. They have the power to do that. And so if we wanted to encourage integration of legal advocacy and tools, paying for them would certainly be a way to do that, and would go a long way. I think there's a lot that also has to happen in terms of culture change, right? So something that is very different about the way that we work at the consortium is an intentionally collaborative model. And that is a hard thing to do, right? It takes more time. You have to work with people who have different training and perspectives and goals that you do. But I think what we found is that these big complex problems are never going to get bridged without people willing to come to the table to work together on them. So I think, finding ways to incentivize providers to work with people in the community and to include patients in those conversations. I think there's a whole host of things that could be done. And states have the ability to pay for and incentivize these things as well.
Again, if anyone has any questions, feel free to drop it in the chat or raise your hand, or you can go ahead and send me a direct message. And Sarah, from someone that just follows the news on the daily or on the weekly, and just not totally knowing as much about this subject as obviously you are, because you are the expert, and you touch so much on legal services. Is that um, the way that we should view this, in the sense of, not only should we view healthcare as a system that is improving and that we need to improve, but at the same time, I think a lot of people probably don't think in the back of their minds, well, legal services needs to be a specific part of this because of uh, fraud and through advocacy and through price gouging. How does the attachment of legal services truly get there as part of the conversation, and how can people on this Zoom call be able to note that in conversations with others when speaking about healthcare with their friends and their family?
Yeah, well, I mean, there are lots of barriers, right? There are a lot of perceptions and misperceptions of the legal profession, in some of which are kind of fair, right? So our legal system, there have been a few reports in the last couple of years, including in California, about the fact that the majority of legal needs of people, of regular people, go unmet. So we have a lot of lawyers, but the needs that people have, that are really critical to their health and well-being, such as around housing, such as in, healthcare access, long-term care access, are going unmet. And the systems that we have for legal aid to help capture people are sort of woefully underfunded and equipped to deal with those needs. So, people think of lawyers as, in the health, relative to the healthcare system, as being those people that come in and sue you. So that's how a lot of healthcare providers initially react when we talk about medical legal partnership. And then people in the lay public don't have a high level of legal literacy. So the research that has been done has shown that the primary barrier to accessing legal services is actually not cost, although that's a factor. It's that people don't understand that there are legal tools or solutions to the problems that they are facing. And so they're not self-diagnosing their own need for legal services. And so, how can we overcome that? Well, we need to, I think those of us in the legal community need to think about how we can talk to our family and friends, but importantly, talk to the folks in our community who should know about legal services but don't. So one thing that sort of is shocking to me, we have in our county and in every county around the country something called AAA, an area agency on aging that coordinates social services for older adults and people with disabilities. And it's often very clear to me that other social service agencies don't always understand what the lawyers are doing or the importance of the role. And that shines through in national reports about services for older adults and people with disabilities. The legal services piece is not shining through as a piece of this puzzle and something that's really critical. And I get asked the question all the time, well, what are lawyers doing that social workers can't? Right. So there's a lot of just like misinformation or misunderstanding about the skill sets that lawyers can provide. And then, a lot of it is structural for the legal system as well. We don't invest in and we don't train lawyers necessarily to focus on the needs of low income and middle class people.
Well, it sounds a lot about kind of changing the culture slowly with a slow shift through a public lens point of view about what the law can do in terms of helping with these types of programs. David asks, have models from other countries been studied and incorporated into the programs you discussed? And do any of those better integrate legal services? That's a wonderful question. I know you presented that graph in the beginning about spending, the differentiation with other countries.
Yeah, it's a great question. So I have not, you know, I'm not a comparative legal scholar, so I'm not the best person to speak to this. What I can say is things like the medical legal partnership model are getting exported from the US to places like Australia. Other countries sort of fund legal services differently. And so that can have an effect. I showed you that slide earlier with the 4 kind of trends that lead to Mr. S's situation. And I'll recommend to you a book called The American Healthcare Paradox by Elizabeth Bradley. And one of the things that she points out in general is that when you look at the ratio of health to social service spending, we all know that the US overspends compared to other developed countries on health services generally. But what is also true is that the US dramatically underspends on social services, period, relative to other countries. So it's those 2 things together that are really important. And so I can't speak to the particular mix of legal services available in other countries. But you know, if you have certain structural supports, you also have less of a need for a lawyer, right? If resources are easier to get, like I actually don't think you should have to have a medical legal team to navigate settings of care, but this is the system that we have built. And so that is why I think we need it.
Another question here from Shepard. I think it's a 3-part question, and I love 3-part questions. So
Okay.
I guess we'll take it one step at a time here. There's a slide that show our uh, incidence on multiple illnesses and implications thereof were worse in the U.S. and a bunch of other countries. Why is that the case? Second, I know you kind of just touched on that. Second, given the complexity of the law, health issues, and critical role of patient navigator, why do we create some incentives for adopting this system approach, solving medical life issues for the threatened population here? For example, if you can show that these complex problems are solved more efficiently this way and thus saving us money on collective resources, tax dollars, insurance premiums, etc.
Yeah, so thank you for the question. So why, you know, do we have worse health outcomes in the US than other countries? There are a lot of explanations for that, but as I shared, for us, we spend a lot of our dollars on health care in the United States, and we spend a lot of our dollars on a specific kind of healthcare. So we have sort of an institutional bias to where we spend our healthcare dollars. So you know, Medicare will cover a hospital visit and Medicare will cover, you know, time in a sniff. But it is not as easy to get coverage, to get help paying for resources in the community. And we know that it is actually from kind of years of public health research, we know that healthcare accounts for somewhere between 10 to 20% of population health status, but that social conditions account for kind of everything else, with genetics playing a little bit of a role. So, you know, when you think about, I should also say we have not invested in public health and we have not invested in primary care. So, you know, all of those things that keep us healthy in the community and out of the hospital, that is very fragmented and harder to pay for, harder to access. The things that we pay for that are easy to access are hospitals. And hospitals are not good places to be unless you're really, really, really sick. And so this is how we've designed our healthcare system. And so there's the healthcare piece. And then as I described, like the social care spending really doesn't set people up to live and age in health. And so all of those things taken together help explain why we underperform relative to other countries. And then I think your second question about patient navigators and incentives. So as I sort of described to Charles, I think payment incentives are really where it's at here. So having a mechanism to reimburse for patient navigator time, for recognizing them as part of the healthcare delivery system, making sure that they are trained and supported. They will get adopted if they are shown to be efficacious, which they are starting to be shown to be efficacious, and if there is a mechanism for hospitals to bill for that time. And then in terms of efficiency, I think, so as I explained, the sort of an average cost per day in the hospital in the US is somewhere between 2,500 and 4,000, depending on the market. And so if you think about the cost per day to have someone in the hospital, that cost is really worth it if that person has a hospital level of care need, right? So if it's worth the risk, right, of being in the hospital, because there is medical risk to being in a hospital, particularly during a pandemic, right? So if it's worth it to be in the hospital, if that person needs to be in the hospital, that is money well spent. But for people like Mr. S, what we're saying is he doesn't have a hospital level of need. He doesn't want to be there. And there are other interventions in the community that are cheaper, that align with his goals, and that are less expensive than healthcare systems. So a lot of organizations, there is a trend to develop a business case, basically, an ROI to hospitals for social care interventions. And one of my concerns is that everyone's sort of competing for that space, rather than saying, what would the right bundle of services look like, and how much would that cost, and how could we do that? And I should say that there's already a model that's sort of similar to this called the PACE model, that Medicare already pays for, but that just hasn't been kind of widely adopted and disseminated. But it's a similar idea. It gives responsibility for somebody's care to an entity in the community, and basically says, if you can provide care for this person for less than a cost of their stay in a nursing facility, we'll give you that money, and you go provide for their care in some other way. So there are the bones, there are the ideas here to do this. And we're in a really interesting sort of phase where people are trying to figure out what is the best way to do this. And so we'll see kind of how that all shakes out. I hope that answers your question.
Thanks, Sarah. And thank you so much for your question, Shepard, and also for your question, David. And big shout out here to Susanna, who writes about her work, and that things are slowly getting better, and the work is complex, and evolving. And I know, Sarah, you kind of noted on that. And I guess I have a final question, that's somewhat negative, but also I want to end on a positive too. Everybody knows that COVID exposed many flaws in our healthcare system, and we lost a lot of seniors and folks with disabilities during this time. And of course, we're still in the pandemic, as we're talking here today. But what kind of work was done to quickly kind of progress in this year and a half, all of these programs that you mentioned and that you're a part of? And then the second piece of the question, because I guess I'm a two-part question person, this final question is how folks on this call can get involved, and to be advocates in their community on a daily basis.
Yeah, great question. So I think you sort of hit the nail on the head. The tragedy of COVID is, as you said, that it exposed what a lot of us have known for a long time, which is that health does not affect all of us equally. And as someone said, we may all be in the same storm, but we're not all in the same boat. And so I think what, the silver lining in this truly awful period is that not understanding of those health inequities, together with sort of awareness around racial injustice has really helped shine a light on the need for these tools. And there's been a lot of energy around trying to figure out solutions. And I certainly see with our students that they are sort of done debating. They want to know what we can do, and how, as future lawyers, they can be a part of that. And that's really exciting to see. And it's true, whether they are in legal aid or if they're going to be a risk manager at a hospital, we want people thinking in a problem solving way and thinking about these issues no matter what practice setting they end up in. So I think that's been really positive from the perspective of faculty at Hastings and in my research. I also think, it has set the stage for a real national conversation about how to address these issues. And as I mentioned earlier, some of that is showing up in the kinds of legislation in the soft infrastructure bill that is being debated right now. That is a conversation that many people have been working for a very long time to have happen at the federal level. So that's really exciting. And then, what can folks here do? At a very personal level, these issues are personal to all of us, right? So we all will be older someday. If you do not have a disabling condition now, you will as you grow older. And we also have family members and we have friends who are experiencing these systems now, or who are going to soon. And so it would be really good to start having those conversations with the people you care about. So, have those planning conversations. If you work in this space, reach out to healthcare providers. It is well worth your time because they see people who need help now and they don't have the tools to do it. So what I would say is join us. we need more people it's going to take a lot of us in our own lives, and it's also going to take a lot of us working together with and for the community in order to kind of scale this work. So grab a shovel and come on in.
Thank you so much, Sarah. I appreciate it. I'm sure that everybody on this call and lecture today and program, however you want to call it, show, whatever you want, at lunch with the expert, learn something and get your shovels ready, folks. Again, Sarah is a 2008 graduate and proud of alumni of UC Hastings Law and the executive director of the UCSF, UC Hastings Consortium on Law, Science, Health Policy, and lecturer here at UC Hastings. Just a quick note for all of you, if you want to send this program to your friends and family, this program has been recorded, so you can. Let's get some other shovels in the ground too. So you can find that at uchastings.edu/alumni within the next 12 to 24 hours. And this will be up as well. So anyway, I just wanted to thank everyone for your time today. And we will be back with another lunch with the expert next month. Thank you for your time and your support. And thank you once again, Sarah, for today. Take care, everyone, and have a great day.
Thank you, Sarah.